and today I'm going to be talking about the update on vocal cord palsy, latest developments in assessment and treatment. Firstly, I'd like to thank the organisers, particularly Jay, for asking me to be part of this amazing head and neck conference, and I wish you all the best for the rest of the morning. So today we're going to explore current etiologies and some red flag presentations of vocal cord palsy, highlight modern assessment methods, review updated treatments, and discuss just very briefly bilateral vocal cord approaches, including emerging pacing technology, and present a UK-focused clinical pathway. So, unilateral vocal fold palsy is much more common than bilateral. That's the main thing to say. Primary causes in the UK are thyroid and parathyroid carcinomas, cardiothoracic injury, or cardiothoracic pathologies, and really any neck surgery. Significant patient impact on voice, swallow, and aspiration risk with vocal cord palsies, but it can really vary in its presentation. In the picture here, you can see a left vocal cord palsy or left vocal cord immobility, as seen in nasendoscopy. In A, you can see the vocal cords in vocal cords. This person would be pretty aphonic, and there would be significant aspiration risk potentially. So a full range of causes would include thyroid surgery, parathyroid surgery, carotid surgery, anterior approach for ACDF, so it's the neurosurgical approach for neck surgery, essentially. Thoracic surgery, and can be also caused by intubation. Neoplastic causes include vagal nerve tumors, skull-based lesions, apex of the lung cancer in the apex, and large mediastinal lymph nodes. They may be infectious or idiopathic causes, including viral neuritis and post-COVID presentations. There may be trauma related, like neck trauma, like stabbings, brainstem lesions, stroke, and demyelinating disease from central causes. So always image the chest and the mediastinum from skull base to the arch of the aorta. As you could see, the recurrent laryngeal nerve runs all the way from the skull base down to the arch of the aorta on one side and around the subclavian on the other. So red flags are progressive voice symptoms, aspiration, weight loss, and stridor. If any of these are present, then you need to be really thinking about cancer. So, assessment, what are the current standards? Well, what can we do? History tells us most of the information that we need, actually, with vocal fold palsy. Patient-reported outcome measures are also very useful to see the extent of how it is affecting the patient itself, and that really helps us when we decide what to do and how we treat this. So certain problems that we regularly use are the VHI-10, the EAT-10, and the some voice and swallow diaries, and in our practice, the Airway, Voice and Swallow questionnaire. We would always do a flexible nasendoscopy and stroboscopy. Of course, if the vocal cord, if there's no mucosal wave, the stroboscopy won't show much. And it would be wonderful to use high-speed video endoscopy whenever it's available. Prognostic tools can be very useful, especially when planning surgery. Laryngeal EMG, which has to be done at the very least at 2 weeks, and could be done up to 6 weeks, but can be done after that time, can show reinnervation potential, can prove denervation, and may even show synkinesis, particularly at later stages of investigation from the onset. Translaryngeal ultrasonography is also a useful tool, particularly when you don't have access to endoscopy. Many cardiothoracic wards or cardiac wards may have access to ultrasound far easier than using endoscopy, and that can be a fabulous way to screen for vocal cord palsies in their post-op patients. This was certainly something that I saw when I was at Great Ormond Street Hospital in use. Imaging protocol. Well, as I mentioned before, CT contrast from the skull base to the aortic arch, so that they can see the entirety of the recurrent laryngeal nerve, is important in order to elucidate any cause. And an MRI is also very helpful if a central or vagal, if there are any central or vagal signs or skull-base pathology suspected. Now, what's new in assessment? Well, I guess the translaryngeal ultrasonography is pretty new in reducing early nasendoscopy, and certainly is used around the world. Early LEMG to inform timing decisions is also pretty new and is not ubiquitously used even in the UK. This high-speed video endoscopy is also not available everywhere, but can provide objective kinematic metrics. And emerging is the AI-driven analysis for acoustic and endoscopic output. And so I guess watch this space for how AI can help us. So here, I just wanted to introduce a red slide. Now, red slides I have put in here in various points just to highlight really the most important slides. So I'm just going to talk about non-surgical and office-based interventions. In particular, voice therapy. I think all patients with unilateral and bilateral vocal cord palsy require voice therapy by our speech and language therapy colleagues, who I think should be part of the entirety of the workup with these patients. They can really help with improving breath support, work on resonance work, and semi-occluded vocal tract exercises. Speech and language therapy are also integral in improving and promoting swallow rehab, particularly when there is dysphagia. They can really help with focusing on compensatory strategies, and can perform functional endoscopic, FEES, which looks at the functional way or endoscopically of how people swallow. And indeed, they may also use video fluoroscopy to also assess swallow. Botulinum toxin is rarely used, certainly in our practice in guys, with regards to vocal cord palsies, but can be useful in the later stages of cord palsy when there is some synkinesis related spasms, which are rare. And the last thing done in office is an injection laryngoplasty or injection medialization, which I will discuss in a little bit more detail in a moment. Now, what are the other surgical treatment options that are done mainly in the theatre? So these are maybe injection medializations done under general anesthetic. They're done endolaryngeal, transorally, and I will go through show you some video of that later. Thyroplasty, type 1 Ishiki thyroplasty, is done either under local anesthetic or general anesthetic. In our practice at Guy's, we prefer to do it under local because we can get immediate feedback as to how the voice sounds by listening to the patient once we place the implant. And also general anesthetic laryngeal reinnervation, usually in our practice using the ansa cervicalis to the recurrent laryngeal nerve under general anesthetic. So they're the options, and I'm going to be going through some of those individually. So let's talk about injection laryngoplasty or medialization in a little bit more detail. There are a number of approaches, and I'm going to show you some pictures of transoral or percutaneous performed in office and in general. I'm going to be talking about different techniques, whether you could do a bit of slight over medialization and particularly getting that voice feedback under local anesthetic. I'm going to talk about different materials and also that early injection, hopefully within 2 to 3 weeks, really helps voice and swallow. But it's really important to counsel everyone on the resorption rates and need for repeat injections. So which injection material do we use? Well, we aim whichever one we use to have the same endpoint with regards to you want it medialized, the vocal cord which is lateralized, you want it medialized. A good test or a short-acting injection material is hyaluronic acid or Restylane. We would normally counsel people that these would last for about 3 to 6 months, can last less, can stay for longer. There are a few things with this. They can have an allergic reaction to that. And we have seen this. It forms, looks a little bit like a hematoma, granulation formation. If this is the case, we can use an enzyme, which the body also has, to degrade it. The next one up is Renu voice, or we used to use Radies. Renu is calcium hydroxyapatite, and this is pretty good for palliative patients, those who would like a longer term injectable. We say it lasts for between 6 and 18 months. Again, this is completely variable to the patient. But it's a nice material to use. Fat from the person, so harvesting fat from maybe the stomach, lower abdomen, indeed. We spin this down and cut it up, put it into a substantial kind of needle gun in order to inject these. Now, these can be done under local, but usually are done under general anesthetic. And it's a good one if people have had radiotherapy or cancer in the past, but they tend to resorb over time, over a few years, and may need a second injection or even a third. And although it's a nice natural material, it isn't really deemed a permanent solution. I'm just then going to talk about tensor fascia lata, as collagen doesn't seem to be used much and Vox has gone out of favor. The tensor fascia lata is well used in Finland, and Ahmed Grenade has a wonderful lecture on this. I have not yet used this myself, but I'm very keen to. You get the tensor fascia lata, a small sample of it from the lateral thigh, which can be done under local anesthetic, and again injected under local anesthetic. But for the learners, we feel that doing this under general is better. And in the past, certainly Teflon had been used, and I have actually seen this in a patient uh, over the years. So different approaches. Firstly, transcutaneous. I'm going to show you a video of cricothyroid. So the angle, so going into the cricothyroid membrane and angling up, and I'll show you the video of that. Thyrohyoid, we're just going to show just a picture of that. What we like is a double bent needle so that it's kind of 90 degrees eventually. And transthyroid, I've never seen this used in practice. I would think with most people with calcified cartilages, this wouldn't be something that would be very easy. So certainly in your armamentarium, make sure that you can do cricothyroid and thyrohyoid. Most people, I'd say in the UK, prefer the thyrohyoid approach. My preferred method is the transoral approach under local anesthetic. So you have your assistant in the nose with the nasendoscope, and you go in with the camera, with the with the transoral needle through the mouth, and ask the patient to show us your tongue and kind of try and breathe and mist a mirror whilst you hold onto their tongue really gently, place the needle down into the larynx, and you get really good, nice feedback. Also, of course, you can do it under general anesthetic, under microlaryngoscopic or an endoscopic approach. So essentially, you don't need very much for your setup. So in the outpatients or theatre, you just need a trolley. You have your local anaesthetic spray or your injection. Generally, for the local anaesthetic spray, we use some cofenocaine for the nose, some xylocaine, 10% for the oropharynx and the tongue. And then we can dribble some more cofenocaine into the larynx, onto the epiglottis, and at the front anterior commissure, so that then it dribbles. Ask the patient to gargle essentially. So they say E, and as you're dribbling the local anesthetic onto the vocal cords, the local anesthetic is spread all along the vocal cords as they say E. Then they're all, particularly for local anesthetic, they're all numb. And that's brilliant for transoral injection. That's all you need. If you do use a percutaneous approach, you're obviously going to place the lignospan or lidocaine with adrenaline in either the cricothyroid or the thyrohyoid membranes at the front. You obviously need your stack system, whatever you do. and your injection material, whichever one you've chosen. You then use either a 23 or 25 gauge needle or a long blue needle, which you have manipulated the shape. So, fairly recently, we have discovered that the urologists have a wonderful needle that is actually strong enough but thin enough to go through our endoscopic channel. It's called the Williams Cystoscopic Injection Needle by Cook, and this can be used with Renu, which is traditionally a very thick material. And so this is a really exciting way of injecting your material, and pretty easy as it's all through the endoscopic channel. So watch this space. I think many more people will be using this technique in the future. So preparation of the patient is really important. Having a meeting, discussing with the patient and advising speech and language therapy pre and post intervention is crucial. We say that voice rest for 24 hours is very important to prevent the extrusion of material. Refrain from any throat clearing. Huff if needed. So I'm just going to demonstrate that instead of coughing, or instead of that, asking them to huff, which is this, which obviously brings the vocal cords into like this type of motion. Instead of coming together, it just stuns the vocal cords, so that it brings the propels the mucus that's stuck on the vocal cords. We say that when we do local anesthetic, that they can't eat and drink for an hour post-injection, but then can eat and drink freely after that. And we do counsel them to say that the voice may have a really strained quality post-injection for a few days. And during and after the injection, ear pain is expected in some, and it will pass, but it may take about 24 hours to pass. Where do you do the injection? So I'm going to show you two places. A, which is just lateral to the vocal process at the end of the membranous part of the vocal fold, and at B, which is kind of on the kind of mid point of the membranous vocal fold, but they both should be lateral to the arcuate line of the vocal fold so that it doesn't go into the superficial lamina propria or anywhere into the vocal cord itself. So you can see at the end of the dotted line, that's where I would aim to be injecting. I put the bevel in adults going downwards. So with regards to going at bevel towards the length, you see towards the length where I would want the material to migrate down. So if you see here, sometimes we will inject to the midline. Sometimes we will do an over injection. And that just depends on the material that you choose. This is what we want to avoid, injecting into the vocal cord itself. If you do see a bleb in the vocal cord itself, try and milk this out. The material will be able to extrude from the needle hole. So this is the surface markings of the thyroid notch and the cricothyroid membrane. And you can see where the arrow is pointing is the cricothyroid membrane. That's exactly where you want to locate the cricothyroid notch area, and palpate and just put the needle through, and you inject until a desired position is achieved by sight. So this video is courtesy of Mr. Karigama. You can see that the needle has come in through the cricothyroid membrane, and the camera is really close, and you can see underneath. Once you have found the right place and you're injecting, you can bring the camera slightly back so you can get a better perspective of where you are injecting. As we're running out of time, I'm just not going to show you this one, but this is the augmentation for the thyrohyoid percutaneous approach. This is what it looks like on the neck. And this is suspension microlaryngoscopy injection. So you have either a tubeless field or a tube in situ. You find your point A, you press it, you inject. And as for the interest of time, I'm just going to speed this up a little bit. You can see that that's medialized somewhat, but then we need a little bit more. So when we go to endpoint B, lateral to the arcuate line, and then you can see far more injection material has an effect. As you can see, even it's going right up to the anterior consia and giving a nice result. So obviously you really need a good visibility, so get a good assistant, particularly when you are doing it under local anesthetic. You want to try and avoid coughing, so good local anesthetic, avoid spillage and wrong site injection. So if they have sub or supraglottic injection, you need to look out for that, and also look out for a hematoma. If people are really hoarse post or they feel airway compromise afterwards, see them quickly and see if they have a hematoma. This is just an image of spinach. And if that happens, just ask them to huff. So post-injection advice, as we said, no by mouth for 1 hour, home the same day, voice rest 24 hours, review. Just you can review at 1, 3, 6, 12 months. And of course, obviously, if it spontaneously resolves, then brilliant. But if not, then either re-injection or other interventions may be required. Really fear the gag reflex. Really try and avoid, if during a recent infection or hypersensitive to the larynx, try and keep it nice and tame, and treat those reflux if it is present. Use adequate local anesthetic, avoid sedation if possible, get a really good assistant, beware of the anticoagulant. Always, for me, in my practice, I would always stop anticoagulants in time. For example, aspirin 7 days, clopidogrel 7 days, rivaroxaban 48 hours, enoxaparin 12 hours. Do not inject into the Ranke space, do not inject into the vocal cord ligament. Know all the approaches but master one, and obviously beginners should start really in theatre but be prepared to convert to GA if local anesthetic doesn't work, and explain to people it may not completely restore their voice, certainly won't make them into opera singers. So the latter part of this presentation is all about the other surgeries. So framework surgery, type 1 thyroplasty, and aretinodissection. These are for persistent glottic insufficiencies. Aretinodissection is very good if there is a posterior gap or a height mismatch. And the implants in use in the world are Silastic, Gore-Tex, titanium, 3D printed, and voice implants. I like intraoperative voice checks, and it really minimizes risk by doing under local. We use the voice implant most often now. This is a nice way to, as a standard approach, to be able to change the position of the vocal cord, and it also gives nice posterior medialization, which means that the aretinodissection is needed less. Reinnervation, primary recurrent laryngeal nerve repair in intra-op injuries is really important for those doing thyroid surgeries, for example. But what we tend to do is answer cervicalis to recurrent laryngeal nerve, and that really works for long-term function. It takes about a year for it to have a full effect, but it really offers great outcomes, and would be our choice for younger patients seeking a physiological recovery. I thought it'd be really interesting just to see one case with regards to reinnervation and LEMG. This is a 28-year-old man who had a left vocal cord paralysis from a neck stabbing 12 months before. And this again is courtesy of Mr.
One,
Paragon.
2, 3, 4, 5.
You can see that he's pretty dysphonic, lateralized vocal cord on the left with pooling of saliva.
1, 2, 3, 4, 5.
So we did preoperative laryngeal EMG, and on the right cord, we got some really nice signals. But on the left, you can see the signals just aren't there, and you've just got some spontaneous waves. So we did the operation, did reinnervation of the left side.
5. Monday,
You can
Tuesday,
see that there's
Sunday.
better function.
Monday, Tuesday, Wednesday, Thursday, Friday, Saturday,
voice,
Sunday.
less saliva in the piriforms, brilliant mucosal wave. And we did post-op LEMG. So pre-op, remember on that left side, there were no signals, just spontaneous potentials. 12 months afterwards, brilliant good signals. So it's a really nice way to prove that everything has worked. So very briefly, bilateral vocal cord immobility, this may be for a number of reasons. 50% of those with bilateral vocal cord immobility will require a tracheostomy, but 50% don't. If they do need some extra support, static airway procedures like posterior chordotomy, partial medial arytenoidectomy, these are destructive procedures and irreversible. So you need to choose your patients wisely. You can also do the Lichtenberger suture laterofixation, which can preserve voice a little bit better over extensive tissue loss in certain cases. Emerging is laryngeal pacing, which are some PCA muscle pace implants in clinical trials, but not used in the UK thus far. So just to show you one way of thinking about a vocal cord palsy. So either unilateral or bilateral. You have the presentation of hoarse voice, poor swallow after surgery, for example. If you know that is definitely immediately after surgery, potentially you don't need to do the CT. You could, sorry about that, if you knew the underlying cause, you could just monitor it. If you don't know, you would do the CT, neck and chest, plus or minus MRI, brain and skull base, as discussed before. So bilateral vocal cord palsy, is there airway compromise? Yes, you would obviously secure the airway if you needed to with a tracheostomy or a surgical airway. If there wasn't airway compromise, and of course this is usually in the unilateral vocal cord palsy, you would want to do LEMG. Now, again, you have to wait till the second week, after the second week to do that. But between weeks 2 and 6, it will give you some prognosis as to the recovery potential of the nerve. If they're symptomatic with voice or swallow, an early injection, we know, is better and leads to better outcomes in the future. There has been studies to show this with speech and language therapy. However, if they aren't symptomatic, you may want to just do speech language therapy alone if needed, or just monitor. Then you really want to reassess once you have done the injection by about month 3, 4, or when the symptoms are kind of not improving. If they are improving, then just again, conservative follow-up at 12 months. But if they're not, you want to start planning your procedures. If you could be considering type 1 thyroplasty with plus or minus arytenodeduction, whether or not you go for reinnervation. And of course, if it's bilateral vocal cord palsy, do you want to be doing some airway enlargement or pacing? So By 6 to 12 months, you're seeing them again, and you may see some recover late. You may require revisions of, injection laryngoscopy, or you may even have to put botulinum toxin in for synkinesis. But hopefully by 12 months, you've made your decision. If it's still not working, to go ahead and medialize if necessary in either one of the aforementioned ways to treat unilateral vocal cord palsy. So the clinical decision making really depends on the age of the patient, the etiology, the comorbidity, occupation, expertise and equipment of obviously who's doing it, and cost and availability. And that will differ wherever you are in the world. Key points just to remember as my time is up, really think wide, image the entire vagus, make sure you've done your CT scan to make sure that the whole of the recurrent laryngeal nerve root has been looked at in uncertain cases. Think about some modern assessment, use embedding laryngeal EMG in your armamentarium, high-speed video endoscopy, the ultrasound, and AI where possible. Try and bridge recovery with early injection. This really improves function and reduces aspiration risk and has better outcomes in the long run. Durable reconstruction. Think about reinnovation for young people. It's physiologic and really long-lasting. And think about the emerging tech. Pacing for bilateral vocal cord palsy shows really early promise in dynamic airway management. So thank you for listening. I hope you have a wonderful day. If you do want to get in contact, there is my email address, and I'm on LinkedIn and Insta. Any questions?
That's a fantastic lecture, Natalie. I think Natalie is in the call now. If you want, you can put your questions in Q&A. We can answer that one. You can type your questions, please. I think already Natalie has been answering it. Oh, that's great. Thank you. That's fantastic.
Yeah,
So,
I can make if we've got a couple of minutes, I'll just
yeah, please. Yeah.
expand. So someone says, how do you assess superior laryngeal injury post-laryngectomy? Yes, we can use full video stroboscopy, particularly looking at pitch glides, looking and hearing at the same time. So seeing if the cords are stretching, feeling the neck, see if there's any cricothyroid narrowing, but also really measuring the pitch range. And obviously it will be reduced in superior laryngeal injury. Also, you can use LEMG, and there's a great website for anyone interested in LEMG, laryngealemg.org. So it's lemg.org. And they have a full protocol on there, which is amazing when you can use that as a base, and it also gives you examples of some of this, like spontaneous electrical activity that we saw on the LEMG in the next stabbing. So you can do that. I see. What is the channel endoscopy needle you mentioned in your presentation? It's a cystoscopy needle you mentioned. Yes, I think it was called the Wilson's. It's a Cook Medical injection needle. We actually found it this week by the urologist. Yes, it's called Williams cystoscopic injection needle. Right, do you need the patient to have total voice rest for 24 hours post-injection? I would definitely give total voice rest. I don't want any intervention to go to waste. I don't want the injection material to escape at all. And I feel it takes probably about 24 hours to fully seal. They do sometimes have a little bit of a cough afterwards, just because the just irritation of the larynx, the numbing then wearing off. So actually sometimes a bit of saline nebulizer to help try and prevent some of the irritation as well. But I would definitely give 24 hours of voice rest. We also give a little badge which says I'm on voice rest, which we ask them to wear afterwards. So that can be really useful. Um, there's another question. Do you recommend immediate vocal cord medialization post vocal cord palsy after thyroid surgery? What's your approach? Well, it's known that early medialization actually lends itself to fewer interventions in the future. So for me, certainly I feel that it can improve both voice and swallow and sense of breathlessness afterwards, even if it's pretty immediate. So we have cardiothoracics on site and lots of head and neck. And if we can, we will try and do the injection before they go home on that first in that first instance, in that first stay. So, I think gold standard practice would be, yes, just inject with Restylane, something really short acting in the first instance. Do we have time for any more questions or?
Yeah, please go ahead. Yeah, great. Thank you.
Someone asked, is there an interesting study on vocal cord assessment by translaryngeal ultrasound? I just PubMeded it, put it in PubMed. There are lots of papers published around this. It is used in practice, particularly where they don't maybe have ENT on site, or in children where they don't want to distress them with an endoscope, particularly if they're cardiac patients. So that's where I feel the endoscopic ultrasound really endoscopic ultrasound, translaryngeal ultrasound is really useful in those patients, and as even like a screening tool. Do you use more than one Renu voice injection syringe for the transoral route, considering the dead space within the long needle? Yes. So the dead space, it depends which needle you're using, and yes, depending on how big the gap is, we may need more than one. What is nice, I think the dead space in this new endoscopic needle is less. So you can also inject air afterwards to try and not air into the vocal cord, but air once you've injected as much to the hilt, then you can draw some air and put the rest, because there's about 1 mil, between 0.7 and 1 mil in the dead space of the needle. So you can use that if need be. Let's see. And the permanent injection, yes, tensor fascia lata, it's the lateral aspect of the thigh. You just, like you're harvesting, fascia, anywhere around the ear or anything, it's just the same. You make a cut superficially on the lateral aspect of the thigh. You only need a small portion of the tensor fascia lata, and you cut it up in really mush it, and you literally just put that into the needle injection gun, and that works well. Maybe one more. Any experience of requiring a higher volume of injectable fillers for elderly patients? Lacks soft tissues and very expandable parapharyngeal fat space. The fillers would fill these spaces first before medializing the vocal cords. Any workarounds? I haven't actually had too much of a problem with that. I think if you place the injection in the right spot, just next to the vocal process, that really does push that back in. And putting the bevel, I think that the site of the bevel is really important. Like I said, if you put the bevel, so you're doing a local anesthetic, awake one, and the bevel is basically facing the anterior commissure. You want to put it in with the bevel facing anterior, so that the injection material will then fall down towards the anterior, as in will be pushed anteriorly, and it literally just expands it anteriorly, and it's brilliant. If you have the bevel pointing outwards, as in laterally, then the injection material will just go laterally, and it won't push the vocal cord medial. So you really have to think about how you place the bevel of the needle when you're doing the injections. I hope that helps. Yes, the point about the arcuate line. So you see kind of like the vocal fold itself, then you have the line, and then the other side is the thyroarytenoid muscle. You want to go just at the edge of the arcuate line, not into the vocal cord, so that you don't want the injection material going to the vocal cord ligament or the superficial lamina propria. So you need to be just lateral to the arcuate line so that it pushes the whole body across rather than seeping into the vocal, the 5 layers of the vocal cord itself. I believe it's the Storz injection needle for fat. Yeah, it's the one with the kind of I don't know what it's called. But yeah, I believe it's the Storz injection needle. Is there a difference when you use it in children? I've actually never used it in children, but I can't imagine it would be any different if you did use it in children. I think that's
Brilliant.
all the questions. Thank you
That's
so much, Jay. What a wonderful day you've got, and thank you so much for inviting
it's
me.
fantastic. Thank you. It's a great talk that you have given. I think very simple and explained it very nicely. I think it's loads of interesting questions. I'm very thankful for your time. I know you're on call as well. Thank you. So we'll move on to the